All right, good afternoon to everyone, and welcome again to this NCLEX review series. So, welcome specifically to Patricia, Dominic, and Ubili. My name is Dr. Tom Madayag, and I will be presenting to you the third series of this NCLEX review. And today it's going to be a continuation of what we talked about yesterday. Yesterday, we talked about heart failure and some of the medications that were given in order to rectify the situation. Today, we're going to continue, however, with the management or the medication management with pharmacologic interventions for patients with cardiovascular disorders. So this is a common thread of questions that appears in the NCLEX quite frequently, and therefore we're going to talk about today medications that affects the renin-angiotensin-aldosterone system, beta blockers, calcium channel blockers. And let's go ahead and begin. All right. When we talk about blood pressure, we talk about blood pressure yesterday being determined by the product of cardiac output and systemic vascular resistance. So there are numerous factors that interact with these variables to keep the blood pressure within normal limits. So as illustrated in the slide, if you take a look at it, blood pressure is determined by two primary factors. What are they? Well, they include your cardiac output and your systemic vascular resistance. You remember the systemic vascular resistance we referred to yesterday as the afterload. So cardiac output refers to the amount of blood that's pumped by the heart per minute, whereas the systemic vascular resistance is the force or the resistance offered by the blood vessels to the flow of blood. So always remember of this equation, blood pressure is equal to cardiac output multiplied by systemic vascular resistance as a balancing act. So the question that I want to pose to you is, what is normal blood pressure? Can you please answer the question, what is a normal blood pressure? Okay, it's good. Dominica and Patricia were saying 120 over 80, and it also depends on the age. Well, you're partly correct. However, I want you to remember that the normal blood pressures have been revised by the guidelines of the American Heart Association. A normal blood pressure should be less than, not 120 over 80. It should be less than 120 over 80. So it is important to note that while 128 over 80 is considered the threshold for normal blood pressure, individuals that have numerous factors, I should say, like age or comorbidities and specific clinical scenarios can actually influence what is going to be normal or ideal for a particular patient. But I want you to look at the slide right now. If you have a blood pressure of 120 over 80, for example, that is already considered to be elevated blood pressure because a normal blood pressure should be less than 120 and systolic and a diastolic of less than 80. So that's one thing that I wanted to emphasize, first of all, that whenever individuals have a blood pressure of 120 over 80 and higher, we begin to teach them interventions or things that can decrease their blood pressure. Okay, so today we're going to talk about hypertension and the drugs that are going to be used for hypertension. And they include your ACE inhibitors, your angiotensin receptor blockers, which we talked about yesterday, your alpha blockers, your beta blockers, calcium channel blockers, and diuretics. And these are some of the medications that we're going to be talking about today. Okay, so hopefully that we will all finish the information that is prepared for you. So let's begin again with a review of the renin-angiotensin-aldosterone system. So yesterday I talked about the RAS, and we're going to talk about it again today as a review in order for you to recall the important facts about the renin-angiotensin-aldosterone system. All right. So whenever there is a decrease in blood pressure that is sensed by the kidneys, and the particular parts of the kidneys are going to be your JG cells, they detect this decrease in blood pressure. They now release a substance called renin. And meanwhile, the liver has a substance called angiotensinogen. And the combination of these two produces another substance, and that would be angiotensin 1. Now, when angiotensin 1 circulates into the lungs, there's going to be an enzyme that is present in the lungs, and this enzyme is what's called ACE, or which stands for angiotensin converting enzyme. And this angiotensin converting enzyme now converts this angiotensin to an active form called angiotensin 2. And angiotensin 2 has so many effects in order to raise the blood pressure. One of them is going to be vasoconstriction. So when you have vasoconstriction as a result of the effects of angiotensin 2, you therefore increase your blood pressure. Now, there's another way in which this angiotensin 2 is going to increase the blood pressure. You remember there was a decrease in blood pressure, and that's why the body is trying to correct it by this angiotensin 2. And the other way in which it's going to cause an increase in blood pressure is to release antidiuretic hormone or vasopressin from the posterior pituitary gland. And so with ADH, there's reabsorption of water. Now, the other way is to release what's known as the aldosterone. And aldosterone is a hormone that's released by the adrenal gland. And aldosterone has two functions. One is to reabsorb sodium. And so when you reabsorb sodium and water, these both will increase blood pressure. And the other one is it eliminates. Now, why is it that this is important? It is important because it is believed or theorized that the majority of cases of hypertension is as a result of a dysfunction of the renin-angiotensin-aldosterone system. We don't know why some individuals are going to have an abnormal release of angiotensin 1 and angiotensin 2. And that is the reason why they develop hypertension. So this becomes the basis then of our understanding of how antihypertensives will work. So before we go any further, what I want to do is to see if you understood the mechanism or the physiology of the renin-angiotensin-aldosterone system. So let's answer this question. Okay, very good. So you all understood that angiotensin converting enzyme is the one that converts angiotensin 1 to its active form, which is angiotensin 2. All right, so there are two correct answers over here. It causes vasoconstriction, letters C and D, and as well as the release of aldosterone and ADH. So C and D. Okay, so now you got the foundation of understanding, therefore, the renin-angiotensin-aldosterone system. So the first classification of drugs that we're going to be talking about today are your angiotensin converting enzyme inhibitors. You remember, this is the enzyme that transforms angiotensin 1 to angiotensin 2. And they're easy to identify because all you have to remember is that all these medications end in the suffix "pril." So an example of that are your enalapril, your lisinopril, ramipril, benazepril, as well as captopril. So these medications are going to be ACE inhibitors. So let's trace first how these ACE inhibitors are going to work. So we said that there was a decrease in blood pressure, abnormal renin release in the body in hypertension. And we have this angiotensin 1 to angiotensin 2, and angiotensin 2 will cause vasoconstriction. That's one effect. Now, if you're going to stop this, the conversion of angiotensin 1 to angiotensin 2, therefore you will not have vasoconstriction, you will have vasodilation, and therefore you're going to have a lowered, a lowered blood pressure. Okay, so that's how these ACE inhibitors work. So in looking at the mode of action of these drugs, the primary effects are cardiovascular and renal. Their cardiovascular effects are due to their ability to reduce blood pressure by decreasing systemic vascular resistance or afterload. All right. So as we had said, the mode of action is that it inhibits ACE or angiotensin converting enzyme, and therefore it can inhibit aldosterone secretion. And if you remember what the functions of aldosterone are, they're going to reabsorb sodium. So by inhibiting this, you're going to prevent sodium and water reabsorption. And therefore, you have a diuretic effect. You will have diuresis, and therefore you will have a decrease in preload. So all these mechanisms, therefore, are going to be useful in the management of patients who have hypertension. Question. Okay, so let's take a look at this question. Which statements correctly describe how ACE inhibitors work? So it inhibits the renin-angiotensin aldosterone system. That is correct, because if you are going to inhibit the ACE that converts angiotensin 1 to angiotensin 2, you're now interfering with the renin-angiotensin aldosterone system. So specifically, it prevents conversion of angiotensin 1 to angiotensin 2. Now, angiotensinogen is going to be the one from the liver, and it does not convert or prevent the conversion of angiotensinogen to angiotensin 1. And lastly, it exerts a positive chronotropic and negative inotropic effect on the heart. Well, if positive chronotropic means to say that you have an increase in heart rate, And a negative inotropic effect would be a decrease in the force of cardiac contraction. These are not effects of ACE inhibitors, and therefore they are not going to be a correct option. All right. So now another question. Very good. So you all understood that letter B is the correct response. The reason is it ends with the suffix -. Now, as I told you yesterday, anytime you see a suffix ending with -ol, that means to say that this is a beta blocker. And anytime you see a suffix that ends in sartan, this is what's known as an angiotensin receptor blocker. And depine, this is a calcium channel blocker. So anytime you see depine or di in a drug, that means to say it's a vasodilator. Calcium channel blockers are also vasodilators. All right, so that's an easy way to remember or to recognize what the drug is for by looking at the suffix of the medication, the generic name. Okay, all right, so obviously, what do we use your ACE inhibitors for? Well, angiotensin converting in enzyme inhibitors are the most commonly indicated medications for the treatment of cardiovascular and renal diseases, including heart failure, and acute coronary syndrome. Now, it's obvious that it is going to be useful for patients with hypertension. They inhibit or they effectively lower the blood pressure. And that means to say both systolic and diastolic blood pressure. And therefore, they're going to be very effective in the management of patients who are hypertensive. Now, as you could see over here, it says recommended as an initial therapy for non-blocks. Now, the reason is non-blocks, our belief is that, or the theory is that, the problem that they have hypertension, or the reason why they have hypertension, is because of an abnormality in the renin-angiotensin-aldosterone system. Now, for blacks, the reason why they are hypertensive or they may develop hypertension is because of their sensitivity to salt. So it's another explanation of, or the theory to explain why blacks develop hypertension is different from the theory of why non-blacks develop hypertension. So it is therefore good to treat patients who have hypertension and they're non-blacks with ACE inhibitors first. And then we could also start with calcium channel blockers, thiazide diuretics, and angiotensin receptor blockers. Now, for our blacks, the recommended therapeutic intervention is to start them with thiazide diuretics and calcium channel blockers. This has been found to be more effective in managing their hypertension. Okay, so that is its use on hypertension. And the other one is, it is indicated for the management of heart failure. ACE inhibitors are strongly recommended as first choice therapy in patients with heart failure. And they're going to be the choice because it decreases the afterload, it decreases the preload, it decreases wall tension, it increases cardiac output without any increase in heart rate, and it reduces myocyte hypertrophy. Now, you remember that if these were the normal cells, the size of the cell of the heart, whenever we have hypertrophy, their size becomes bigger. And that is why they're called hypertrophy. And of course, this could be a effective treatment to prevent this from happening. All right. So aside from hypertension and heart failure, where else or what else can we use your ACE inhibitors for? Well, they're very effective in the management of post myocardial infarction patients. Over the last few decades, uh, evidence have shown that ACE inhibitors decreases mortality and morbidity on patients who have had a myocardial infarction. And they also slow down the progression of complications such as heart failure in patients who have had a myocardial infarction. Another indication of your ACE inhibitors are for diabetes. The renin-angiotensin-aldosterone system, and because it increases glomerular capillary pressure, have been reported to actually decrease the complication of diabetic nephropathy. So this slows down nephropathy and it decreases the incidence of diabetes associated with myocardial infarction. So that's one other thing that is going to be the reason why we use it in patients with post myocardial infarction is to reduce the possibility of developing diabetes as a consequence of myocardial infarction. Okay, so there are other areas where we could use your ACE inhibitors. And they're very effective in patients who have renal disease or prevention of the progression of renal disease. An example of that would be your nephrotic syndrome or proteinuria, or patients who have developed a lot of proteins in their urine. So it has been shown that the use of ACE inhibitors prevents the progression of albuminuria and even proteinuria. And it is going to be useful for chronic kidney disease. ACE inhibitors, or even angiotensin receptor blockers, are actually the first-line drugs in managing chronic kidney disease patients. They have been proven to have a superior effect in slowing down the progression of kidney disease. It has demonstrated that it actually decreases proteinuria. Now, I wanted to emphasize that yes, this is going to be very good to prevent the progression of advanced kidney disease. However, it should not be given to patients with end-stage renal disease. And the reason why it is contraindicated in end-stage renal disease is because ACE inhibitors increases potassium levels in the blood. And so if you have end-stage renal disease, you also have hyperkalemia, thus it should be avoided. All right. So it is useful for the management of early chronic kidney disease, but not end-stage renal disease. Next question. Oh, I'm so proud of you. Okay. So your ACE inhibitors will cause a decrease in systemic vascular resistance or afterload, and therefore it's going to decrease blood pressure. Very good. It also is going to excrete more water and sodium, and the kidneys will now retain more potassium. Now, you remember that constriction of blood vessels is an action of your angiotensin 2. If you block the conversion of angiotensin 1 to angiotensin 2, you therefore will not have constriction of the blood vessels. And of course, it decreases systemic vascular resistance. It does not increase it. Excellent. All right. So the correct answer is letter A. Why not letter B? You remember we said that it should not be given in patients with end-stage renal disease because of the retention of potassium. Now, it's the same thing with somebody with severe renal failure. When you have severe renal failure, you have an inability to excrete your potassium. And therefore, the major electrolyte problem in patients who have end-stage renal disease and acute renal failure is hyperkalemia. So letter B is incorrect. All right. So what are the contraindications for the use of ACE inhibitors? Well, it has potential for causing actually allergic reactions. So angioedema is a situation wherein blood vessels are going to be inflamed, and this is a manifestation of an allergic response. So it could also be contraindicated if you're having other medications like a direct renin inhibitor, as well as potassium-sparing diuretics. So remember, this is a very common question in NCLEX. Why is it that it is contraindicated to be used with potassium-sparing diuretics like spironolactone? So any diuretic actually that is going to end with actone are potassium-sparing diuretics. The reason is, remember that one of the actions of your ACE inhibitors is that it's going to produce reabsorption of potassium. And therefore, the potential for hyperkalemia in conjunction with, or if used with, a potassium-sparing diuretics is going to be very high. And the last thing is that it is usually contraindicated in pregnancy. All right, so are there special side effects or precautions that we must observe in patients who are receiving ACE inhibitors? And the first one is a dry, non-productive paroxysmal cough. There's no treatment for this cough, but the good thing about it is that it actually is temporary, meaning to say that it will disappear eventually. And so this is not a dangerous side effect, but it becomes bothersome for some patients. So I want you to remember to teach the patient that if they develop a cough, it doesn't mean to say that they're getting worse or that this is a bad effect of the drug. Now, in the event that these patients are not going to tolerate the cough, then the prescriber usually are going to switch them to another antihypertensive medication, and usually it will be the angiotensin receptor blockers. The other thing is, we had mentioned already about the possibility of an allergic reaction. So we want to make sure to observe them during the first few doses of the drug. And because it lowers down blood pressure, then we are going to monitor the blood pressure so that we can detect any potential hypotensive events. And most important is that it can cause hyperkalemia. The reason being is there's going to be a reabsorption of potassium. Okay. Now, another complication or another precaution, I should say, in the use of ACE inhibitors is that some patients will complain of a metallic taste in their mouth. And this could even last even after you have discontinued the drug. So this is one complication that, or uh, side effect, I should say, that does not have any treatment. It just disappears in approximately 3 months. And then, of course, we never use it for severe renal failure or end-stage renal failure. And therefore, we always have to make sure that we check for your serum creatinine and renal function tests. All right. So there's a black box warning. Remember what black boxes are. Black box warning is going to be a requirement by the FDA that any manufactured drug, whenever there is a potential for a very major side effect, it must be labeled in the drug, on the drug, that is going to have this bad side effect. And so black box warnings are usually high yield in the NCLEX. In other words, when you're going to have questions related to drugs and there is a black box warning to a drug, it's most likely to be that question that they will ask. So remember, no to pregnancy. Okay. Now, the side effects are easy to remember by just remembering one of those ACE inhibitors drugs. Captopril is one of them. So captopril is going to be a mnemonic that you will need to remember in order to identify all the side effects associated with ACE inhibitors. C stands for cough, A stands for angioedema, P, pregnancy problems, meaning to say that you should not give it to patients who are pregnant. Taste changes, you remember that this could be even after 2 to 3 months after discontinuing the drug. Other side effects like rash or fatigue, proteinuria, renal insufficiency for R, I, increased potassium or hyperkalemia, and of course, L for low blood pressure. So that's a good way to remember the side effects of your ACE inhibitors by remembering captopril. Next question. Oh, you're all so smart. Okay. So a patient complains of annoying persistent dry cough after taking ACE inhibitors. What is the best response? So we need to reassure the patient that this is a harmless effect. A dry, persistent cough is a well-known side effect of ACE inhibitors. And therefore, it is important to tell patients that they might develop this problem. Okay. So we finished with ACE inhibitors, and now we're going to go to the next type of drug to manage patients' hypertension. as a result of an erratic RAAS, or renin-angiotensin-aldosterone system. So if you recall, going back to your renin-angiotensin-aldosterone system, all right, so a low blood pressure is going to stimulate the release of renin from the JG cells of the kidney, and renin, in addition to angiotensinogen from the angiotensinogen from the liver, is going to produce your angiotensin 1. And with ACE, this is converted to angiotensin 2. From angiotensin 2, it's going to find receptors that will welcome it. And this is going to cause all those things like release of aldosterone, your release of ADH, your vasoconstriction, and so on. Now, angiotensin 2 receptor blockers, these are the ones that you are blocking with these drugs. They're called ARBs, angiotensin receptor blockers. So we are blocking the receptors to angiotensin 2. When you do that, you obviously are going to prevent an increase in blood pressure by blocking vasoconstriction, by blocking the release of aldosterone, by blocking the release of ADH. Okay? So they're easy again to remember because they end in the suffix sartan. So as a recap, what is the mode of action of angiotensin receptor blockers? It blocks angiotensin 2 and the receptors, I should say, and it primarily affects vascular smooth muscle. So it is effective in blocking vasoconstriction. It also blocks the secretion of aldosterone. So when you block the secretion of aldosterone, you remember aldosterone reabsorbs sodium, you're now going to block the reabsorption of sodium. It is going to decrease blood volume. When you decrease blood volume, you decrease blood pressure by decreasing preload. Okay, so what are some of the examples of ARBs, or angiotensin receptor blockers? Your losartan, olmesartan, valsartan, candesartan, or irbesartan. Okay. Okay, so metoprolol ends with olol. They are beta blockers. Losartan is the correct answer. Any drug that ends with sartan is an angiotensin receptor blocker. Lisinopril, it ends with pril. It is going to be an ACE inhibitor. And nicardipine, which ends in dipine, this is going to be a calcium channel blocker. Okay, so Brielle is going to be ACE inhibitors. Nicardipine is calcium channel blockers. All right, so what are the indications of your ARBs? You remember that ARBs are going to decrease aldosterone, they decrease ADH, they decrease peripheral vascular resistance. They also decrease blood volume by interfering with the reabsorption of sodium and water. So therefore, these are going to be good for managing hypertension. And you know what? Another thing that they have found is that it actually is very useful to prevent diabetic nephropathy. So, in patients who are diabetic, they usually are given ARBs, despite the fact that they might not have hypertension. The reason for that is because evidence have shown that there's going to be a protection on the kidney by reducing intraglomerular pressure. And therefore, they slow the progression of diabetic nephropathy. They also have been found to be very effective in reducing the leakage of protein in the urine, known as proteinuria. So, which is a key marker of diabetic nephropathy. And lastly, it is also recommended in patients with heart failure, especially in patients who are intolerant or cannot tolerate your ACE inhibitors. The reason why it's effective in heart failure is it reduces afterload. I explained what afterload was yesterday. It also reduces preload. And therefore, by doing this, you're improving cardiac output and reducing the workload of the heart. Now, in addition to that, you remember that when you have a myocardial infarction, what usually happens is that the areas that have been infarcted become scar tissue. And so, if this was, for example, the ventricles, this might develop as a scar tissue and no longer moves. And therefore, there's going to be a change in the anatomy or um, the shape of the left ventricle. ARBs have been found to prevent cardiac remodeling or the change that is associated with the development of scar tissue in the heart after a myocardial infarction. Excuse me. Okay, so now let's take a look at the side effects of uh, angiotensin receptor blockers. The most common ones are actually mild, and they might include headache, dizziness, and drowsiness. Well, obviously, it could also cause angioedema, hypotension, and tachycardia, as well as hyperkalemia. So it's very, very important to remember to emphasize to these patients not to increase potassium in their diet or should not take any potassium supplements. Okay. So ARBs could also cause, in some instances, tachycardia. And again, the black box is going to include avoiding administration in pregnancy. Now, if we remember the side effects of ACE inhibitors by remembering captopril, we also can use the mnemonic in one of these drugs, particularly losartan, uh, and we can now remember what its effects are, or side effects are. So losartan, the L stands for low blood pressure. Others, including fatigue, headache, dizziness, swelling, and this is related to angioedema, allergic reaction, raised potassium, teratogenic, no to pregnancy. It may cause acute kidney injury. And this one is a mild or an unusual side effect of the drug. Some patients will complain of nasal congestion as well as dizziness. So this is a mild side effect of the medication. Okay. Okay, so you remember that both these drugs are going to increase your potassium levels. And this is a very common question in NCLEX. But remember that they are going to have a potential for hyperkalemia. If that is the case, you're going to tell patients to avoid exaggeration of potassium-rich foods. What are some of the potassium-rich foods? Well, you have your oranges, for example, you have your potato peels, as well as other vegetables that are high in potassium. Okay, so let's take a look at another question. Okay, let's take a look. I think some of you are confused. It says, what are the effects of angiotensin receptor blockers? All right. So remember that these medications are going to be used to treat high blood pressure. So it is going to cause vasodilation, right? If you're going to cause vasoconstriction, you will increase the blood pressure. So this would not be a correct response. And if you conserve sodium and water, this will raise blood pressure. You certainly don't want to do that, okay? And that is why you use ARBs to control the blood pressure. And water excretion is correct, all right? So by blocking the effects of angiotensin 2 on aldosterone secretion, your ARBs reduce sodium and water retention. So this promotes water excretion, and therefore it would help decrease blood volume. And if you decrease blood volume, what happens to blood pressure? It will be decreased as well. All right. Patricia,
Would it be the same thing if it was a Pearl?
Uh, with the
It would,
Prill, yeah, you remember ARBs and Prill are the same, are similar. And so therefore that would be a good generalization of it. Okay?
okay, because I confused it just now. So
Yeah.
it
So
will,
both of
it
them.
cause, it cause vasodilation.
Yeah,
The only way it causes vasoconstriction if if it's not converted.
correct. If
Oh,
there is going to be your angiotensin, I mean your angiotensin 2 and your ARBs. So you remember angiotensin 1 converts to angiotensin 2. All right. So angiotensin 2 causes vasoconstriction. So if you block the receptors for this, you will have vasodilation. The other one is ADH and aldosterone. And aldosterone, if you know or remember, is the one that we absorb sodium and um, eliminates potassium. So if you block this, you will have the opposite effect. What's going to happen is that you will have sodium excretion, and potassium will be reabsorbed. Okay? So those are the things that you are going to be doing when you're giving an ARBs or even an ACE inhibitor. Okay, so you remember that sodium is going to be potassium is going to be reabsorbed which causes hyperkalemia. And Patricia has a very, very good point. And I'm glad that you reminded me, Patricia. Whenever we're teaching patients about potassium, we teach them you're not going to exaggerate your potassium intake, so avoid these foods. So one of the most common things that we forget are salt substitutes. Why is that? Remember that salt is sodium chloride. Now, when you are giving or using a salt substitute, it is potassium chloride. So therefore, salt substitute should be avoided anytime you want to avoid hyperkalemia. Okay? Thank you, Patricia. That's very good. All right, so what are some of the responsibilities of the nurse related to angiotensin receptor blockers? Well, we want to make sure that in addition to assessing the blood pressure, we also have to monitor the labs. In particular, we want to monitor the potassium levels because the risk for hyperkalemia is going to be very high. The other thing is that we want to make sure that the kidneys are working well. An elevation in the BUN and the creatinine means to say that this is going to impinge on normal renal function, as well as liver enzymes. And of course, we want to emphasize to them that they should avoid potassium high foods and no salt substitutes. Okay? I just explained with the reminder from Patricia why we don't want substitutes, and examples of high potassium foods are going to be oranges, banana, potato peel, and others. Okay? All right. So that ends your ACE inhibitors and your angiotensin receptor blockers. We're going to take a break, and when we come back, we're going to talk about beta blockers and calcium channel blockers. So let's go ahead and take a 5-minute break. Okay, the alarm is on. It's time to proceed with the next topic that we have, and that's beta blockers. So, what are beta blockers? Well, I want to bring you back to the autonomic nervous system so that you will understand this. And so, we have the autonomic nervous system, which controls the involuntary automatic functions. And so, we're all too familiar with this. And the autonomic nervous system, we know, consists of the sympathetic nervous system as well as the parasympathetic nervous system. So, oh, my pen is, here you go. So the autonomic nervous system consists of the sympathetic nervous system and the parasympathetic nervous system. The sympathetic nervous system is mediated or takes its effect by a hormone, and this hormone is adrenaline, or also known as epinephrine. And that is why this system is what is called an adrenergic system, or the sympathetic nervous system. And the other one is the parasympathetic nervous system. And this is mediated by another hormone, and this one is acetylcholine. And that is why another name for the parasympathetic nervous system is cholinergic system. Okay, so this is the one that is released as a result of stress from the adrenal gland. This is a release in order to rest and rehabilitate. Okay, so we're going to look at the sympathetic nervous system. When we talk about the sympathetic nervous system, we're talking about the effects of adrenaline. Now, when adrenaline or epinephrine is released from the adrenal gland, what's going to happen is it's going to look for doors that welcome it. And one such door is going to be known as the alpha receptors. Alpha receptors happens to be abundant in the vascular bed or the blood vessels. And so when epinephrine or adrenaline enters these alpha doors, they cause the blood vessels to constrict, and therefore it raises the blood pressure. So you can just imagine if you have a medication that is going to block the alpha receptors, then you're going to have your decrease in blood pressure. Okay, so if you have a medication that blocks this, you will have a decrease in blood pressure. So I hope you understand that. But there are other receptors that are going to be receptive for the entry of adrenaline into their cells. And one such receptors are called your beta receptors. So these are your beta receptors. It's another door for adrenaline to go in. Well, beta doors are actually of two kinds, or beta receptors are of two kinds, beta 1, and the other one is beta 2. Beta 1 receptors are abundant in the heart. And when adrenaline or epinephrine goes into this beta 1 receptors, what are their effects? Well, it increases heart rate. So this is what's called positive chronotropy. It increases the force of cardiac contraction. So this is going to be called positive inotropy. And the other one is that it increases transmission of electrical impulses. So you remember there's an electrical circuit in the heart from the sinus node to the AV node to the bundle of His and so on. And this is called a positive dromotrophic effect. All right, understand that so far? So what I'm saying is that if epinephrine or adrenaline enters the beta-1 receptors, the beta-1 receptors are going to be abundant in the heart, and its effect on the heart is that it's going to increase its heart rate, it's going to increase the force of cardiac contraction, and it's going to also increase the transmission of electrical impulses through the cardiac conduction system. Okay? Now, beta-2 receptors are abundant in the lungs. And so it's easy to remember because we have one heart and two lungs. So what are the effects of beta-2 receptors or epinephrine on beta-2 receptors? Well, this is going to cause bronchodilation, and it could also cause vasodilation, a small amount of vasodilation. Okay, so bronchodilation and vasodilation, but this is going to be a minor effect. All right, so when you block beta, what will you have? You will have a decrease in heart rate, decrease in the force of cardiac contraction, a decrease in the transmission of electrical impulses. In the lungs, you will have bronchoconstriction. Okay? So to summarize all that, let's take a look at it in this slide. All right. So epinephrine can have receptors, and they are alpha receptors. So there's actually two types of alpha receptors, but we're just talking about alpha 1 because this one is more predominant in the nervous system. So the alpha 1 located in the vascular walls, also found in the heart, can increase duration of contraction without increasing the heart rate. Beta-1, found in the heart, causes inotropy and chronotropy. Beta-2, found in blood vessels and the lungs, causes vasodilation and bronchodilation. And then there are other receptors called dopaminergic receptors. We're not going to talk about this right now. Okay? So this is receptor physiology. You have to understand this in order to understand how your beta blockers work. Okay? All right. So let's recap. When epinephrine or norepinephrine or adrenaline enters alpha-1 receptors, which are located in the arteries, they're going to cause vasoconstriction. So vasoconstriction is going to increase blood pressure and increases blood flow returning to the heart or preload. So if you block alpha-1, you're going to decrease blood pressure because you're going to cause vasodilation. So these medications like alpha-1 blockers are going to be drugs that end with the suffix "ocin", like terazosin, tamsulosin. This also has an added effect in that it relaxes the bladder sphincter. So in addition to being effective for the management of hypertension, it is also useful in the management of patients with BPH, or benign prostatic hypertrophy. Okay, so that's the alpha receptors. But we're going to talk about beta receptors or beta blockers. So let's now focus our attention to our two types of beta receptors. Beta 1 receptors, which are located in the heart. When they're stimulated, it increases the heart rate and that increases the force of cardiac contraction. And beta 2 receptors are located in the bronchioles, and they mainly cause bronchodilation, but they also are present in arteries of skeletal muscles, wherein they can cause vasodilation of the skeletal muscles. Okay, the arteries in the skeletal muscles. All right. So now, what then is going to be the effect if you block beta receptors? Well, you're going to cause a decrease in cardiac contraction. That's called a decrease in heart rate. I'm sorry. So that will cause a negative chronotropy. It slows down the conduction velocity. And so this is going to be dromotropy. It is going to decrease the force of cardiac contraction. It therefore decreases blood pressure, and it also decreases intraocular pressure by reducing the production of aqueous humor. Okay? So these are some of the indications, or the mode of action, I should say, of the use of beta blockers. So when we use beta blockers, where are they useful for? Well, they're indicated in patients who have angina. How do they work in angina? Well, if beta blockers causes a decrease in the force of cardiac contraction and also causes a decrease in heart rate, therefore, it is going to be very effective in reducing the demand for oxygen. And that's why it is very useful for patients with angina pectoris. Now, they could also be very useful for patients with myocardial infarction. After an MI, beta blockers have been found to reduce mortality by preventing arrhythmias, and therefore it could also decrease myocardial workload. So if you decrease the force of contraction, you're going to have lesser demands for oxygen. They've been useful for the management of tachycardias, and so cardiac dysrhythmias is going to be one indication. So anytime there's going to be tachycardia, this is going to be a useful drug because beta blockers causes a decrease in heart rate. Because of the effect on cardiac output, then it is going to be very effective in the management also of hypertension. Now, there are some types of beta blockers that are going to be very useful in the management of patients with heart failure, particularly your carvedilol, bisoprolol, and metoprolol. These are one of the, let me just write that down. Okay, I'm sorry. It was All right, so in heart failure, why are they effective? Well, because it has been actually found out that they have been very effective in decreasing workload of the heart. So when you have heart failure, sometimes or studies or evidence have shown that these patients are going to have a better survival rate. Now, it has been found also to be very effective in migraine. Beta blockers, particularly propranolol, are very effective in preventing migraines. It is very effective in the management of glaucoma because they're going to decrease aqueous humor production. And one such drug is timolol. And thyrotoxicosis or hyperthyroidism. Remember, the signs and symptoms of hyperthyroidism include tachycardia, tremors, anxiety are going to be managed by blocking the effects of beta receptors. Okay? Now, I just wanted to point out that there's another use of beta blockers, and that's for stage fright or stage anxiety. And it includes, for example, test anxiety. Now, I don't know if some of you have this particular problem. I know that in teaching thousands of nurses now who have gone to NCLEX, some of them failed the first time because their problem was not lack of knowledge, but because they have test anxiety. And so let me tell you a story so that you might find it useful. Okay, so I studied voice, and so I sing, and I used to be a cantor at St. Patrick in Miami Beach, and I used to lead the singing over there. And so it never bothered me during ordinary times, but Christians usually flock to church during Holy Week. So during Holy Week, the church usually is packed, and it gives me a lot of anxiety. And I couldn't sing very well because I start trembling, I start sweating, I start having a dry mouth, and so on. And so one day, uh, one of the parishioners who happened to be a cardiologist, approached me and said, "Tom, you sound beautifully today." And I said, "Oh, thank you, but I was so nervous." And she said, "I noticed that." She said, "You sound beautifully, but you're perspiring so much, and it looks like you were shaking." And I said, "I was." And she said, "Well, you know what? Have you ever tried taking something for it?" I said, "Well, I used to take, an anxiolytic like Xanax, but it keeps me sleepy and therefore I can't sing very well." And she said, "Oh, that's the wrong thing to do. Why don't you try a low dose of a beta blocker?" And she gave me a prescription for that. And every time I would sing during high holidays, I would take just a half tablet of the propranolol that she uh, gave me, and it would really erase all my anxiety in performing. And so that is one other use of beta blockers. So I'm sharing this with you because if you're paralyzed in your test because you are too anxious, do not take any anxiolytic like Valium or Xanax or any of their benzodiazepines because it will make you less alert. It would be much better for you to use a low dose beta blocker. Okay? So you can consult your physician about that if you really have that problem. All right? Okay. So that was the use of beta blockers. Now, I failed to tell you that beta blockers, let me go back to the first slide because that was the important thing. They usually are going to be drugs that ends with the suffix -ol. But in some instances, they're going to not end in -ol. And when they do, such as when the carvedilol, for example, carvedilol, it is not ending with olol, but rather all. Or the other one is labetalol. Labetalol is only ending with lol, not olol. This means to say that this is a mixed alpha and beta. Okay? So if they're not ending in olol, they are mixed alpha and beta blockers. And you know that alpha blockers are going to be abundant in the blood vessels or alpha receptors. And of course, your beta receptors are going to be abundant in the heart and the lungs. Okay? All right. So going back now to the beta blockers, there are two types of beta blockers. And beta blockers are going to, what do you call that? Either block beta 1 or block beta 2 or both. Okay. So beta blockers with first letter from A to N are cardioselective, which means to say that they only blocks only beta 1. Okay. These blocks beta 1 and beta 2. So if it blocks beta 1 and beta 2, these are contraindicated in patients with pulmonary disease. Why? Because they're going to cause bronchoconstriction. Okay? So your beta 1 cardioselective drugs are going to be safe for patients who are who have pulmonary disease because they only block beta 1 receptors. Am I clear? So to know which one are cardioselective and non-cardioselective, any drug that is a beta blocker that is beginning with A to N are cardioselective. So they only cause a decrease in heart rate. They cause a decrease in the force of cardiac contraction. They will not cause bronchoconstriction. Okay, so acetabuterol, atenolol, bisoprol, esmolol, metoprolol, nebivolol, all these medications from A to N are going to be cardioselective. Whereas any drug from O to Z that is a beta blocker is going to be both a beta 1 and beta 2 blockers. So they are non-selective. Examples of that is pindolol, propranolol, sotalol, and timolol. Now to drive this very much, remember that beta 1 and beta 2, when you block them, beta 1 is abundant where?
The heart.
Where is beta 1 abundant? The receptors?
The heart.
We have one heart, and beta 2 receptors, we have 2 lungs. Okay, so if you block your adrenaline from going into beta 1 receptors, then you're going to decrease heart rate. And when you decrease heart rate, you could also decrease the force of contraction. And so it's very specific, therefore, for the management of patients with heart problems. Beta 2 receptors, on the other hand, is going to cause, if you block them, you're going to cause bronchoconstriction. All right? So if I give you pindolol, is this cardioselective, meaning to say, does it only work on beta 1 receptors, or is it a beta 1 and beta 2 blocker?
Beta 1 and beta
Pindala.
2. Beta 1 and 2.
For both, right? Because it's non-cardioselective. Very good. So Pindalol, propranolol, sotalolol, timolol, all these medications are indicated in patients with pulmonary disease because they cause bronchoconstriction. Okay, so let's go to the next question here. Yeah. It's not launching. Ah. Okay, I'm having problem with the poll, so let's go ahead and answer this. Actually, the correct answer is heart and kidneys. The oh, so beta 1 receptors are abundant in the heart. In addition to that, I didn't emphasize that very much, is it actually is also present in the JG cells of the kidney. And where their function is, they stimulate the release of renin. So when you stop renin, you also would cause a decrease in blood pressure. Okay? All right. So some of the things that we need to remember about beta blockers are the precautions. Now, there is a black box warning. The black box warning says that you must not withdraw it abruptly. So the patient should be taught never to decrease the dose by themselves, nor should they stop the medication abruptly. What would happen when they abruptly discontinue the drug? It could cause a rebound hypertension, meaning to say that they can have an elevated blood pressure, more elevated than it was before, or they could even have tachycardia. And sometimes the reason why this is in the black box warning is that it causes myocardial infarction. So it is emphasized that you always taper the dose gradually, and it should be done under medical supervision. It is contraindicated in heart failure as well as in Raynaud's disease. It may cause depression, and therefore we need to have or to monitor their psychological state, because again, as I said, it could cause depression or mood changes in some patients. Now, we usually don't use it in younger patients, or particularly male patients, because beta blockers may affect sexual function, and therefore it could cause impotence. It could also cause constipation, and more interestingly is that it can mask the effects or the symptoms of hypoglycemia. So beta blockers can therefore stop the patient from having tachycardia, which is a sign of hypoglycemia. And therefore it makes it harder for diabetic patients to recognize the signs and symptoms of low blood sugar. In addition to that, hypoglycemia usually causes shaking in a patient. Now, beta blockers can decrease the shaking or the anxiety or the tremors that is associated with hypoglycemia. So we have to be very cautious when we're using it with patients who have diabetes. It also affects the lipid profile. It increases triglycerides and decreases the good cholesterol, the HDL, which could have long-term cardiovascular implications. And of course, particularly if it's a non-cardioselective medication, your non-selective beta blockers can cause bronchospasm by blocking beta 2 receptors in the lungs. And of course, we want to make sure, as part of the education, to have the patient monitor their weight and to report sudden weight gains of 2 pounds in 24 hours or 5 pounds in a week, because this in general is an indication that the patient is retaining fluids. Okay, so is there an easy way to remember the side effects of these medications? There certainly is. Think about beta block. So this beta block becomes the acronym for you to remember what are important in this drug. So the first one, B, is for bradycardia. Beta blockers, particularly cardioselective beta blockers, are going to cause a decrease in heart rate. And because it causes a decrease in the cardiac contraction, it could exacerbate heart failure. Do you remember the black box warning? The black box warning states that you must taper it off because otherwise it could cause an MI or it could also cause rebound hypertension. And caution in the use of patients with asthma and COPD and other pulmonary diseases, because if it is non-cardioselective, it could cause bronchoconstriction. Blood glucose could be affected. So meaning to say that we need to make sure that we are going to monitor the patient or teach them to monitor and not rely so much on heart rate as a symptom of your hypoglycemia. And then, of course, it could cause low blood pressure, orthostatic hypotension. It could cause an impairment of circulation because of its constrictive effect. And then, of course, we want to make sure that we know the overdose signs and symptoms. So what would that be? Well, the overdose signs and symptoms would be severe bradycardia, severe hypotension, heart blocks, and of course, you're going to also have mental status changes. So, unknown caller. I'm sorry about that. I'm not going to. Okay. And the other one, as far as the overdose signs and symptoms, what was I talking about? um, well, they could have bronchospasms. Okay. All right. So let's take a look at this question. I don't know if my poll is gonna work. Let's see. It's not working. Okay. All right. Could you just go ahead and answer in the chat box? Okay. All right. So the doctor prescribes propranolol. Propranolol is it cardioselective or non-selective? Is propranolol cardioselective or non-cardioselective? Very good, Dominique. It's non-selective. So which means to say that it could cause bronchoconstriction, right? So this would be a bothersome statement. I use an inhaler at home for asthma. Oh yeah. If you give your propranolol, what's going to happen? Well, it's going to block both beta 1 and beta 2 receptors, and this could lead to bronchoconstriction, making propranolol a poor choice for patients with asthma. So we want to use a cardioselective drug if that is the case. Okay. Select all the beta blocker medications listed below that affect only beta 1 receptors. So we're looking for cardioselective. Very good. I'm so proud of you. So B, C, and D are going to be cardioselective. Anything that begins with O to Z is going to be a non-cardioselective drug. All right. So let's now go to the last drugs that we're going to be using, and that's calcium channel blockers. So whenever we have calcium, we always associate calcium to contraction. So imagine that calcium is going to enter into its receptors. What it's going to do is it will facilitate contraction of muscles. So when we block this, because contraction can increase blood pressure by causing vasoconstriction, when we block this, then we're blocking your vasoconstriction, and therefore you will have vasodilation. So that's the major effect of calcium channel blockers. But obviously there is more. Now, one way to identify calcium channel blockers is that they end in depine. So examples of that would be nifedipine, for example, are medications that are calcium channel blockers. And so how do they work? Well, they block the entry of calcium into the cells. So when they block the entry of calcium into the cells, it's going to cause a decrease in contraction. So you will have negative inotropy, meaning to say that you will have a decrease in the force of cardiac contraction. You could also have a negative chronotropy, which means to say that you will have a decrease in heart rate. And in addition to that, you will have a decrease in the transmission of electrical impulses in the cardiac conduction system. So there's going to be a reduction in firing and conduction of impulses from the SA node to the AV node. And because you're blocking the entry of calcium into blood vessels, it causes vasodilation, and therefore it decreases afterload. Increases, I'm sorry. Oh, that's correct. It decreases peripheral vascular resistance, because when you are going to give calcium channel blockers, that is going to be their effect. Okay, I apologize for that. Oh, all right. So what are the indications or what's the use of these medications? Well, they're going to be very useful for angina because if you decrease the force of contraction, you decrease the demand for oxygen. When you decrease heart rate, you also decrease the workload of the heart. And therefore, it's going to be very effective for angina. Because it causes vasodilation, it's very good for patients with hypertension. And because you slow down the conduction of impulses from the SA node to the AV node, it is going to be very useful for the management of arrhythmias, such as supraventricular tachycardia, atrial fibrillation, or atrial flutter. And it has also been found to be very effective as a prophylaxis for migraine. And this is believed to be effective because it decreases the contraction that is related to spasms that cause your migraine headache. And then, of course, in Raynaud's phenomenon is going to be characterized by numbness, tingling, and color changes in the hands as a result of peripheral vascular disease. Calcium channel blockers like amlodipine improves blood flow to the extremities by producing your smooth muscle relaxation or vasodilation. And it has been found to be very effective in the management of patients who have had cerebral artery spasms related to intracranial pressures. Nimodipine, for example, is a specialized calcium channel blocker used to treat cerebral vasospasms, which oftentimes accompanies subarachnoid hemorrhage. Okay, so let's take a look at this question. A patient with diabetes type 2 and hypertension is on sotalol and insulin. What is sotalol? You remember it is both an alpha and a beta blocker, and insulin, which indicates a lack of understanding of instructions. Let me see what your answers are. The others, what are your answers?
I'm a little stuck on this one, honestly.
I'm sorry, say that again.
I'm like having a hard time picking an answer.
Okay, all right. So let me help you out. If a patient has diabetes and hypertension, and you're treating them with sotalol, sotalol is an alpha and beta blocker. Okay. And the patient is on insulin. If the patient is on insulin, they're most likely to experience a complication such as hypoglycemia. That's one thing that we have to always remember when a patient is on insulin. Thus, a beta blocker affect hypoglycemia. And we said that it masks the symptoms of hypoglycemia. In other words, you are going to have less shaking, you're going to have less tachycardia, you're going to have less other symptoms of hypoglycemia. And the correct answer here is letter C. I will monitor for fast heart rate, a sign of hypoglycemia. Now, you remember that the patient will not have tachycardia because the patient is on sotalol. All right? So is letter A correct? This medication can affect my blood glucose levels. Yes, because beta blockers can decrease blood glucose levels. I will monitor my pulse and BP every day. This is correct. And I will report weight gain or swelling in my feet. This is also correct. So remember, we're looking for lack of understanding. Okay? And this is the one that demonstrates that the patient doesn't understand that if he is on beta blockers, in this case, alpha and beta blockers, he's not going to have the tachycardia whenever he will have hypoglycemia. This is a common question in NCLEX. It has been repeated over and over again. Okay, so I wanted you to pay special attention to this particular question.
I guess like where I was getting confused was like you would want to monitor for that, but what you're saying is that the sotalol would minimize that symptom, so having the monitor for it wouldn't be enough. So they would have
Okay,
to monitor their pulse. So like he wouldn't be feeling the symptoms because of the other medication. That's why
precisely. Okay, so I'm glad that you pointed that out. All right, so if I am going to have hypoglycemia, what are the signs and symptoms of hypoglycemia? One, tachycardia, right? Two, sweating. Give me something else, shaking. Okay, so you understand that these are some of the signs of hypoglycemia. Now, whenever you are on a beta blocker, in this particular, when you're on a beta blocker, these are going to decrease your shaking, decrease your heart rate, so you will not have tachycardia. And what was the other things that we had said right over here? The beta blockers are going to erase those. And therefore, the patient will not recognize that they're having a hypoglycemic attack. All right? So very, very good point, Dana. Thank you so much. Okay. Next. Let's see if you remember the terms. Okay, so let's take a look. Inotropy means force of contraction. Now, calcium channel blockers are going to interrupt with the calcium entry, and therefore it's going to cause a decrease in the force of contraction, a negative inotropic effect. Now, remember that it also causes a decrease in heart rate, and therefore this has a negative chronotropic effect. This is heart rate. And lastly, it is going to cause a decrease in the conduction to the AV node, and therefore this is what's known as dromotropic effect. Conduction from the SA node to the AV node. Okay, so it's A, C, and E. All right, so whenever we're looking at calcium channel blockers, there actually are two types of calcium channel blockers. One are called the dihydropyridines, and they're the ones that actually are going to end in the suffix dipine, like amlodipine, clivedipine, nicardipine, nimodipine, and so on. The other kinds of calcium channel blockers are your non-dihydropyridines, and they include your verapamil, your cardizem, and others as well. Now, the dipines, the dihydropyridines, the dipines, are in the smooth muscle. And so they act over here, and thus they're going to be very effective for the management of hypertension and angina. So amlodipine, felodipine, isradipine, nicardipine, and nifedipine are all dihydropyridines that are calcium channel blockers. Remember that they're abundant in the vascular bed. The non-dihydropyridines, however, are more in the heart, and therefore they're going to be very effective in the management of arrhythmias. So your examples of that drug would be your verapamil or Kalan and your diltiazem. Okay, so in summary, what are the effects of calcium channel blockers? Well, number one, they decrease heart rate. They decrease the force of contraction of the heart. They cause vasodilation. And they decrease the transmission of impulses from SA to the AV node. Okay, so the last one is specific to non-dihydropyridines. All right, let's take a look at the side effects. The side effects of these medications would include headache, dizziness, flushing, and sometimes peripheral edema. Actually, this is very common. Sometimes patients will complain of peripheral edema, especially in the lower extremities. And this is as a result of vasodilation. Hypotension could be a common side effect due to the vasodilation that occurs. And then sometimes instead of causing bradycardia, tachycardia could also occur in dihydropyridines. So this is what is called reflex tachycardia, which is a compensatory increase in heart rate as the body attempts to maintain cardiac output because of the lowered blood pressure. And for the non-dihydropyridines, you will have bradycardia as well as constipation. Verapamil, in particular, is associated with this particular problem because of decreasing the gut motility. All right, so what are some of the precautions for calcium channel blockers? Now, we never give, here in the United States, sublingual for hypertensive emergency. It used to be that we would give them sublingually, particularly nifedipine, but they have found out that actually it causes stroke, and therefore it's not given as a sublingual treatment for hypertension. It is, however, an accepted medication for the management of patients with premature labor. And of course, if this is so, then it has to be released from the pharmacy in a syringe, and it is going to be prepared diluted so that it doesn't cause the risk of causing a stroke. And then, of course, we have to be very cautious about the two forms of cardism. Now, when you have cardism, it could be SR. This is sustained release. SR stands for sustained release, which is not the same as cardism, a CD, which is controlled delivery. There's a difference between these medications. One is given twice a day, and the other one is given once a day. And therefore, you should not confuse the two. Cardism is going to be different from SR to CD. Okay? They are sound alike, but they should not be interchanged with one another. And lastly, grapefruit juice. Grapefruit can reduce the metabolism of drugs, any drug for that matter. So what happens if you decrease the metabolism, it could lead to an increase in plasma drug levels, and this could result in overdose. Okay, so always make sure that you advise the patients to avoid taking in grapefruit, as it is going to reduce the metabolism of these medications. So in as much as this is applicable to any drug, I'm going to explain why grapefruit affects medications. Now, grapefruit contains a compound, and I forget what that compound is, but it interferes with an enzyme that is in the liver, and this enzyme is called CYP3A4. So this is in the liver. This is an enzyme that usually will metabolize your medications. But if you eat grapefruit, somehow or another, it inactivates this enzyme. So the enzyme being responsible for metabolizing many medications are going to therefore stay a higher or longer time in the blood. And therefore, what's going to happen is it will lead to higher drug concentrations in the bloodstream. Okay, so this is for any drug. Anytime you're on a medication, you should never take grapefruit or grapefruit juice. All right, so what are the important implications for the use of calcium channel blockers? Well, we want to make sure that we monitor the heart rate, because if decreases heart rate can cause bradycardia, as well as it could cause hypotension. And because of the decrease in blood pressure, we could have what is known as reflex tachycardia. So we want to make sure that we also watch for that complication, as well as orthostatic hypotension. So we want to advise the patient to rise slowly from a lying or a seated position to prevent falls or even dizziness caused by sudden drops in blood pressure. We also want to make sure that we monitor the ECG, because again, it slows down the heart rate. It could also cause heart block. Constipation measures. So what are some of the constipation measures that we can implement? Well, for example, increasing the fiber as well as the fluid intake, and also physical activity. These are measures to prevent or manage constipation. Now, another thing is that it could cause gingival hyperplasia. So what is gingival hyperplasia? This is when you have overgrowth of the gums. And so what we want to do is to maintain, or to emphasize to the patient, that they need to maintain excellent oral hygiene and regular dental visits in order to deal with this complication. And because digitalis and calcium channel blockers have similar effects we want to make sure that if they're used together, that we monitor for signs of digitalis toxicity. And I talked about digitalis toxicity yesterday, and I said that the first symptom of digitalis toxicity was what? What is the first symptom of digitalis toxicity? GI symptoms. Okay, so it could be lack of appetite, loss of appetite. It could be lack of appetite, nausea and vomiting, and it could progress to ophthalmic signs. And that ophthalmic signs could include a yellow haze or even diplopia. And then, of course, we are going to monitor the digitalis blood level. Remember that anytime digoxin is going to be above 2 nanograms per milliliter, this is now considered to be digitalis toxicity. Okay? And so those are the implications of these calcium channel blockers. Okay, our last question. Your answers? Okay, so let's take a look at this question. It says a patient is on diltiazem. Which findings require the RN to hold the ordered dose and notify the physician? Select all that apply. Okay. If the blood pressure is 198 over 102, actually diltiazem will be good for it. So this would not be it, because that's one of the indications that we would use calcium channel blockers. It is useful. Diltiazem is useful for arrhythmias as well as hypertension and angina. Okay. How about letter B? EKG shows third-degree AV block. If there's an AV block, you remember that calcium channel blockers can also decrease heart rate. And therefore, this would be a contraindication to the administration of a calcium channel blocker. EKG shows atrial fib uncontrolled. This means to say that we need cardism. This is an indication for the use of your calcium channel blocker. And lastly, a heart rate of 46 per minute. Your diltiazem causes a decrease in heart rate, and therefore it's going to be also contraindicated. So ladies, that is the end of my presentation for today. We'll have more pharmacology as far as the high yield pharmacology questions that is anticipated in the NCLEX. So this is our third day, and I hope that you have survived. I hope to see you tomorrow, and we will continue with our discussion on several topics that are important in NCLEX. So, yeah, sure. Could I repeat about the cardism difference? Okay. So there are two types of calcium channel blockers. The dihydropyridines. So they are the ones that end with denes. And the other one is non-dihydropyridines. For example, cardism is one of them. or diltiazem. And then, of course, here, all your dipping. Your dippings. And so whenever we have, let me just go back to that one right here. Amlodipine, clevedipine, nicardipine, amlodipine. So the main difference is your dihydropyridines are going to be abundant on the smooth muscle. So they act on the smooth muscle more. So they are going to cause vasodilation. So the major effect of your dihydropyridines is vasodilation. Your non-dihydropyridines, they're more abundant in the myocardium, and therefore their major effect is to slow down the heart rate and to decrease the force of contraction. Okay? I hope that's clear, Patricia. All right, so thank you, everyone. I appreciate your time. I will see you tomorrow.
Thank you, Professor. Have a good day.
You're welcome, Dana. Thank you, too.